everyone, and thank you for joining us for today's NeuroNexus webinar. We're really excited for today's special guest, Dr. Lindsey Sloan from the University of Minnesota. She's a physician scientist and assistant professor at University of Minnesota, where she serves as the medical student director and co-lead of the Committee on Community and Belonging in the Department of Radiation Oncology. She's a Masonic scholar within the Masonic Cancer Center, and her clinical practice specializes in the treatment of tumors of the brain, including primary brain tumors and brain metastases, with radiotherapy. And we're really excited to have Dr. Sloan here today to share early results from the GESTALT trial, which is the GammaTile sponsored clinical study evaluating the use of GammaTile in patients with newly diagnosed GBM. So Dr. Sloan, thank you so much for joining us today. We really appreciate your time. And you presented this data earlier this year, right?
That's true, at the American Radium Society in Seattle.
And I know it was under embargo for a while, and here at GammaTile, we were kind of patiently waiting for it to be published so we could share this with all your peers. So we're really excited to do that today. So I'll let you take the floor.
Oh, thanks so much. Thanks so much, Ashley. And thanks to GT Medical Technologies for inviting me to give this webinar. I'm excited to also share with you the GESTALT results, or GammaTile Enhanced Stoop Alternative early results relating to REP, or rapid early progression. In terms of disclosures, I'm the PI on clinical trials supported by GT Medical Technologies, and I attend their yearly meeting each year, for which they provide travel support. I'll jump into our results. Rapid early progression, as we've been talking about, or REP, is a significant concern in the treatment of patients with glioblastoma. REP is defined as tumor progression or tumor regrowth between the time of resection and the start of external beam radiation. You can see the two pictures here with the contrast enhancement. This is an important finding when it happens because it's associated with a worse overall progression-free survival and, importantly, worse overall survival. So therefore, our hypothesis of this study is that by starting radiation immediately through the use of brachytherapy at the time of resection as a treatment bridge to external beam radiation, that the rate of REP can be reduced. So as Ashley mentioned, the results shown here are from the GESTALT trial. These are early data. GESTALT is a prospective multi-center single-arm feasibility study. And in this trial, patients undergo resection with intraoperative placement of cesium-131 collagen tiles, or GammaTile. This is then followed by external beam radiation therapy with concurrent temozolomide, similar to standard of care.
So Dr. Sloan, I know today patients, when they receive standard of care, they receive the Stoop protocol. Can you kind of explain what that is and then how GESTALT is different?
Absolutely. So in standard of care therapy, patients undergo a maximally safe surgical resection, so as much tumor that can come out safely does, and then we allow for some time for some wound healing, maybe some changes in the cavity to occur, and then we follow this with adjuvant therapy, which is radiation, often over 6 weeks, for a total of 30 gray. There's some additional protocols that may be indicated based on the patient themselves. And this is given with concurrent chemotherapy, temozolomide, and then this is followed by temozolomide alone and adjuvant chemotherapy, which is given for 6 cycles. So it's quite a package time of treatment, but starts with sort of that adjuvant therapy of chemo and radiation.
And can you kind of explain the rationale for using this immediate brachytherapy at resection to bridge patients until EBRT begins?
Absolutely. So in my mind, this is what makes the GESTALT protocol like a potential game changer. So due to factors, like I mentioned, the wound healing, we need to wait to initiate adjuvant treatment, so the chemotherapy and radiation. And this sort of wait time is about 4 to 6 weeks. So the idea is basically you're bridging the patient, getting them started on radiation therapy at the time of surgery through the use of the collagen tile brachytherapy until the external beam radiation plan can be created. And that surgical incision is healed. So it's basically getting started on treatment earlier.
That makes a lot of sense. And, a common question we get about GESTALT is that, GBM is a diffuse disease that's established. Brachytherapy is a localized treatment. So how does the Gestalt protocol work around these things?
That's a great question. So, and something that comes up quite often, because some people may say that maybe brachytherapy has already been looked at, sort of in glioblastoma, but not really in this way, because Gestalt has a second, basically application of radiation where we match fields with the brachytherapy dose to give the external beam radiation that you would expect from one of those standard of care plans. So it's just getting the early treatment and the focused treatment with the brachytherapy, but also being thoughtful of the idea that glioblastoma is a very diffuse disease. So that's factored in. So in this early report, we looked at 30 patients with glioblastoma per the WHO 2021 classification system, and they were recruited over a period of about 2 years. We evaluated the postoperative and the RT planning MRIs to identify REP. 70% of these patients had undergone a gross total resection, and as we would expect of these patients, about 30% of them had MGMT promoter methylation. So we looked at the 30 patients evaluated. Only 6, so 20%, were found to have REP. And we compare that to the recent published meta-analysis rate of 46%, which is obviously much higher. Importantly, the median MRI interval in patients who developed REP was only 16.5 days. So we didn't think this was reflective of a delay in treatment. But instead, the fact that glioblastoma is really aggressive and it's a really hard diagnosis to treat. When it was identified, REP was most often found adjacent to the cavity, which includes the tiles. And this is similar to what we know about patterns of recurrence in glioblastoma after standard of care therapy. And only in one case did REP occur distant from the cavity and therefore distant from the GammaTiles. Often, rapid early progression occurs around the cavity. And in our case, it only occurred once distantly out of those 30 patients. So on the other hand, rapid early response, or RER, is the decrease in contrast-enhancing tumor between the postoperative MRI and the start of external beam radiation. So you can see this example case with the green circles. You can see in multiple planes that there's decreased enhancement, in these cases where GammaTiles were placed next to areas that were not able to be resected. So 3 of 9 patients had less than a gross total resection, and they were found to have RER. And this is has the potential implication that collagen tile brachytherapy may have the ability to actually induce early tumor regression. So in conclusion, the REP rates thus far in our study are only 20%, which is much lower than historical values, that 46% I mentioned before. And so far, the rapid early response rate, or RER, was about 33% in those 9 patients who had less than a GTR. So that's also very encouraging. So the accrual for Gestalt is now complete, and we're looking forward to seeing these results on safety and feasibility of integrating collagen tile brachytherapy into the standard of care treatment for glioblastoma. So this concludes my presentation. Ashley, thanks so much for having me on this webinar. Do you have any questions or anything I can answer?
So what do you see as the most important next steps in research to validate and expand upon these early results?
Great question. So the next step, I think, which you're already working hard on, is a randomized trial to test the efficacy of the Gestalt protocol compared to standard of treatment, which I believe is called BRIDGES, very appropriately so, as bridge therapy. But I understand that this is going to be opening soon, and I know here at the University of Minnesota we're really excited, and we're going to be trying to get that open as soon as it's available.
Thank you, Dr. Sloan. This is really compelling information, and I know we're excited to unveil the BRIDGES protocol at the fall medical meetings this year. Just one follow-up question. So what potential role do you think GammaTile can play in reducing REP and improving survival outcomes across even broader patient populations?
Yeah, so we actually think about this a lot. So because we know that Gestalt is sort of an upfront, a trial that patients enroll with before they go to surgery. So we do think about other histologies, but glioblastoma is not the only tumor type where we find changes, that we're not expecting on our simulation scans. So I think it would make a ton of sense to evaluate for, the potential role for GammaTiles and REP in other aggressive CNS histologies, such as, grade 4 astrocytomas, even some grade 3 astrocytomas, and definitely in high grade meningiomas. I think that would be a sort of a natural next direction to go.
And then how about in the recurrent GBM setting? Is rapid early progression something you see in that setting as well? And would GammaTile theoretically work for that?
Absolutely. I think the other thing to kind of consider there is the fact that, unfortunately we know that glioblastoma, almost always recurs. When we're thinking about radiation planning, our radiation planning and sort of our focus of treatment when we're evaluating patients for re-radiation is different than in those that have a new diagnosis, and we are less focused on the on sort of the diffuse areas and more interested in controlling contrast enhancement. So I actually think that that it would be really interesting to study the potential role for GammaTile in a formal way for those with recurrence. But I know that our center has had some good experience with using GammaTiles in this way.
With glioblastoma, we know it almost always recurs. So after a patient has been treated up front with GammaTile, say on the GESTALT trial or even off protocol, how do you treat recurrence typically in your practice?
I think that's a great question because, as you mentioned, unfortunately, it's something that we almost always have to, kind of think about. So I'd say in the case where we either have, strong evidence radiographically, where the patient is, very symptomatic, or we've gone for a re-resection, or we have tissue to confirm that there's recurrence, we kind of start from the beginning and evaluate the patient as a whole. We do have a multidisciplinary tumor board in which we sort of reevaluate certain options for patients. And, sometimes it is appropriate to proceed with a second course of radiation. And in patients that have had GammaTile, we have been able to, continue to consider them for additional treatment. And at least in our experience, they've done quite well and, have not had any additional toxicities that would be, outside of what is expected with radiation. So, we've seen GammaTile as really an additional tool that we've had, and still allows patients to be considered for a lot of options down the line as well. So,
and then I know I've heard of instances where a patient receives GammaTile either in the upfront setting or a recurrence, and then the tumor recurs elsewhere in the brain, another location. Is that a case where you would be willing to put tiles in this second area of the brain? And can you explain your rationale behind that?
Yeah, I mean, I think one element of that is the great part about brachytherapy is that it's very focused. I think we'd evaluate sort of as a team, but in my mind, in this case where you have something sort of outside the radiation field, it really depends upon patient performance status. But if they're eligible for resection, for whatever reason, it would be very appealing to have very focused radiation, and especially in this sort of recurrent setting where we're having sort of adjusted fields and focusing more on the contrast enhancement. So I think that would be something reasonable to consider.
All right. Well, Dr. Sloan, thank you so much for your time and this excellent presentation. I learned a lot, and thank you all for joining us today for this NeuroNexus webinar. We do air these webinars monthly, so please keep your eye out for next month's topic. Thank you.
Thank you.